people more. Good evening, all young Turk. I'm Dr. Neeru Takral, National Coordinator, Indian Fertility Society, and National Coordinator, this Young Turk Youth Empowerment Program. You all know we are doing this every second and fourth Friday. Earlier, the time was 7 to 8, but now, because of your convenience, we have changed it to the 8 to 9 p.m. So we are having Journal Club. You all are welcome to present your embryo, welcome to present your cases, your journal club. You can tell us, we are having mentoring session also on the fourth Friday, like how to do MRCOG. Last Friday, we have done about ASHRAE certification program from the clinician. Then we'll be having ASHRAE certification for embryologist, research, evidence-based medicine. All this mentoring session also we'll be doing. So you all are welcome. With this, I invite our expert of the day today, Dr. Parinder. His CV, please, Chaitanya. Yeah. So welcome, Dr. Parinder. He's a great endoscopic surgeon and robotic surgeon from Mahatma Gandhi Medical College and Hospital, Jaipur. So he has got various achievement and awards. YouthCon 2024 award by IAG March 24 at Varanasi, and felicitated by the Indian Menopausal Society in Rajasthan. Runner-up prize in Surgical Youth Icon Award in UFOXY. Chapter in various books like Isthmocele textbook of histoscope. Chapter in the role of adhesolysis under guidance. Histoscopic polypectomy in step-by-step approach. He's the IAG Managing Council member from 23-25, Vice President AGESR, Joint Secretary IAG Rajasthan Chapter, Founder Secretary of Association of Gynae Endoscopic Surgeon of Rajasthan, Founder Treasurer of IAG, Organizing Secretary for Endo-Ferticon 2019 Jaipur. And he's running various fellowship programs. So welcome, Dr. Parinder.
Thanks so much, ma'am.
Next slide, please. So that how to become member, huh? Yeah. So all of you, if still you are not the IFS member, please become the member. We are having various program every month like IFS Genius Junction Quiz, Patient Empowerment Program, Intelligent Empowerment Program, Young Empowerment Program, Council Empowerment Program, Nurses Empowerment Program, Self-Empowerment Program. So every month we are doing this. And it hardly 2 minutes job you can do online. It's a 3-minute process. Next slide. So yes, with this, I invite our presenter, Dr. Chaitra SK. Dr. Chaitra SK is the clinical director and leading fertility consultant at Ovam Fertility Bangalore and visiting consultant at Milan, Bangalore. So welcome, Dr. Chaitra.
Thank you, ma'am. Good evening to all of you who have joined here. I thank IFS for giving me this opportunity to present this study. So today I'll be presenting about Isthmocele. So this study was published in Fertility Sterility in 2024. So the study being Isthmocele, not cesarean section per se, reduces in vitro fertilization success. It's a systemic review and a meta-analysis of over 10,000 embryo transfer cycles. So the background of this study is, we all know that the most common long-term complication of a cesarean section is the isthmocele. It is also known as a cesarean scar defect or a diverticulum, which presents as a pouch-like myometrial defect that forms because of imperfect tissue healing at the site of cesarean scar. So the reason why I choose this topic is that me as a fertility specialist, recently I've been coming across a lot of cases with isthmocele with patients with previous cesarean section. And I was wondering that why all these years I was not seeing so many cases, and suddenly that in the last 1 or 2 years I'm seeing so many cases. Definitely the rate of cesarean sections are increasing. But I was wondering whether I was missing this diagnosis of isthmocele, especially when there was no fluid collection in the intracavitary region or in the lower part of the uterus. So probably this isthmocele diagnosis was probably missed by me. So how do we diagnose this isthmocele? The most commonest method is by a 2D ultrasonography with or without injecting contrast agents, mainly the saline. Although some studies use three-dimensional ultrasonography or HSGs or hysteroscopy or sometimes MRIs to diagnose this. The incidence of diagnosis of isthmocele is about 24 to 70% by transvaginal scans, and it increases to about 56 to 86% if we are using a saline sonography. So for all the beginners, so this is how the isthmocele looks on an ultrasound. It presents as an anechoic pouch which will be seen on the area of previous cesarean scar. So with this background, I selected this study in order to understand and go into the depth whether actually isthmocele is affecting our IVF success rates. So generally the patients present with symptoms like prolonged mens, spotting, chronic pelvic pain, abnormal uterine bleeding in the form of intermenstrual bleed or dysmenorrhea. When it comes to infertility, many people present as infertility either as for secondary infertility because of accumulation of blood and inflammatory exudate in the defect which has been created. So this alters the sperm migration and viability, altered myometrial contractility. It adversely impacts the embryonic vitality. It creates a hostile environment for implantation due to intrauterine inflammatory state. There could be chronic endometritis by bacterial proliferation and dysbiosis. There could be lowered expression of integrin alpha and beta, thereby altering the receptivity, bringing down the implantation rates. So the available evidence regarding the impact of isthmocele and its association conditions on IVF outcomes is unclear. Notably, previous reviews showed a detrimental impact of previous cesarean sections on IVF results. However, these studies did not differentiate whether the impact was because of isthmocele or because of the cesarean section per se. Thereby, it was difficult to ascertain whether the decline in the IVF outcomes was attributable to isthmocele or solely because of the cesarean section per se itself. So this study is a systemic review and meta-analysis where electronic databases from the Science Direct, the clinical trials, Cochrane Library, EU Clinical Trials Register were searched by 2 investigators until May 30th, 2023. The study objective was primarily to compare the live birth rate between women with isthmocele and those without isthmocele after a previous cesarean section. The secondary outcome was to measure the clinical pregnancy rates, miscarriage rates, implantation rates, ectopic pregnancy rates, and scar pregnancy rates, and also the multiple pregnancy rates. The additional analysis includes the comparison of live birth rate between patients with isthmocele or with the previous cesarean section without isthmocele and those with previous vaginal delivery. So all analyses were conducted using random effects model. The effect measures of comparisons were expressed as odds ratio with 95% confidence intervals. A p-value of less than 0.05 was considered statistically significant. Heterogeneity was assessed using the Huygens I-squared statistics. The results were graphically displayed with forest plots. Coming to the result, a total of 8 studies were included in this analysis, which included 10,873 patients, out of which 1,264 women with isthmocele, 6,836 with previous cesarean section without isthmocele, and 2,773 women with previous vaginal delivery. All patients had undergone an autologous IVF ET cycles, either with a short or long antagonist protocol with either usage of RFSH, HMG, with either a dual trigger or an agonist trigger or an HCG trigger. So the embryo transfer were either a fresh embryo transfer or a frozen embryo transfer. Cleavage or blastocyst stage embryos were transferred. and the number being about 1 to 3, and this was followed with luteal phase support. The study results showed that women with Isthmocele showed a lower live birth rates than both women with a previous cesarean section without Isthmocele and those with a history of vaginal delivery. The live birth rates in women with previous cesarean section without Isthmocele and those with a history of vaginal delivery were similar. Again, the subgroup analysis suggested a negative effect of intracavitary fluid in women with Isthmocele on the live birth rates, whereas the live birth rates in women without the intracavitary fluid and those without Isthmocele were similar. So data from a single study also showed that Isthmocele of all sizes were associated with negative effect on live birth rate, with a worsening trend from small to medium to large. Coming to clinical pregnancy rates, on the basis of data from 7 studies, Isthmocele was associated with lower clinical pregnancy rates after both unadjusted and adjusted analysis. Even the miscarriages rates were increased in women with Isthmocele when compared to women without Isthmocele. Implantation rates was lower in women with Isthmocele than in controlled patients, that is patients without Isthmocele and with normal delivery, vaginal deliveries. The ectopic pregnancy rates did not show any difference between the groups. There was no cases of cesarean scar pregnancies which were reported in any of these 8 studies. The multiple pregnancy rates were also similar between the groups of patients with Isthmocele without and patients with previous vaginal delivery. Additional analysis of live birth rates between patients with Isthmocele or with a previous cesarean section without Isthmocele and those with a previous vaginal delivery. So there was a comparison of, we took 3 studies where about 3,485 participants were there. It demonstrated a lower live birth rate in women with Isthmocele. So women with previous cesarean section without Isthmocele versus patients with previous vaginal delivery, the aggregated analysis of data from 3 studies involving 5,000 odd patients did not show any statistical differences in terms of live birth rate between the patients who had no Isthmocele and vaginal delivery. So this is the summary of results. We can all see that live birth rate is higher in patients with no Isthmocele when compared to patients with Isthmocele. Additional subgroup analysis showed that the live birth rate worsened in presence of intracavitary fluid, and live birth rates were similar in patients without Isthmocele and previous normal deliveries. The clinical pregnancy rates, implantation rates were all lower in patients with Isthmocele. The miscarriages rates were higher in patients with Isthmocele. The strength of this study lies in its originality and the large sample size and consistency of results, and there have been a good statistical adjustments of the confounding factors, and fair quality of studies were included in this meta-analysis. The limitations being the retrospective design of the study and the subgroup analysis which was conducted had a smaller sample size, which limits the possibility to rule out a negative effect of Isthmocele without intracavitary fluid on the IVF outcomes. So on this, the conclusion made was that on the basis of the moderate quality evidence, this study demonstrates that the Isthmocele, rather the cesarean section per se, exerts a negative impact on the success rates in women undergoing IVF. The adverse effect of Isthmocele on IVF outcomes appear to be exacerbated by the accumulation of intracavitary fluid before the embryo transfer. Conversely, the potential effect of Isthmocele without intracavitary fluid on IVF outcome remains uncertain because of the small sample size involved in this study. So these are the other articles which were published in Fertility Sterility, showing that this one article published in 2020 September, the effect of an Isthmocele on IVF outcome in infertile patients undergoing a stimulated IVF treatment. it was concluded that large isthmocele with a residual myometrial thickness of less than 3 millimeter was associated with development of intracavitary fluid, and it had an adverse effect on IVF outcome in infertile patients undergoing IVF in COS cycles. This another study published last year in October 2023. The pregnancy and live birth rate outcomes in patients with secondary infertility undergoing laparoscopic isthmocele repair. So in this retrospective study also, it was concluded that there was improved pregnancy rates and live birth outcomes in patients with secondary infertility after a laparoscopic repair of isthmocele, and definitely it should be considered as a primary treatment in women demonstrating large isthmocele with a residual myometrial thickness of less than 3 millimeter, desiring a future fertility. Thank you.
Thank you, Dr. Chetra. So it was a nice study. Next slide, or we can, yeah. So we are having Fertivision, our annual conference on 6th, 7th and 8th of December at Gujarat, Mahatma Mandir Convention Exhibition Center. So those who are still not registered can register. The last date of early registration is 15th September. Next slide. Kshetra. Yeah, so call for abstract 30th September. You all have still time to register and submit the abstract. So last date for early bird is extended till 15th September. So thank you, Chetra.
Thank you, ma'am.
For the awesome, excellent study. We know nowadays in OPD, we are seeing so many cases. So how many cases you are seeing previous cesarean, Dr. Chetra, in your OPD?
Usually I see about 10% of patients with previous cesarean. Among them, previously in my last 8 years
You
of
can stop
patient.
sharing now. You can stop sharing. Yeah.
So previously, like even in previous cesarean patients, I was not probably recognizing these isthmoceles at all, although we had seen fluid in cavity cases and all, but definitely not an obvious defect in the previous scarring and all. Of late, since 1 year, I think in the last 1 year, I saw around 5 to 6 patients like repeatedly collecting this intracavitary fluid, not disappearing with any mode of treatment and all. So finally, last month only we operated 2 patients and their outcome is yet to come. So I thought that definitely cesarean rates are increasing. There is a lot of isthmoceles which we are seeing of late. And there is a lot of confusion whether to offer a surgery for these patients because we don't know the outcome of surgery, whether we will be able to definitely correct these defects and ensure that there is no intracavitary fluid collection appearance again.
And how do you diagnose these cases? How do you confirm the diagnosis?
So most of the diagnosis can be done by a 2D ultrasound itself, where we see an anechoic region in the area of previous cesarean scar. Sometimes if there is no accumulation of fluid there, it might be difficult. A 3D ultrasonography will definitely help. If still in doubt, we can infuse some saline and see that there is a collection of saline in this defect or in the pouch, thereby confirming the diagnosis.
Yeah, sonohistography is also a very good tool with putting saline, and lastly, MRI. Yeah, and Dr. Farinder, why we are having so many cases? What are the predisposing factor? Any fault in the surgery or any genetic factor? Anything you suggest? What could be there?
There are many hypotheses which are there.
Yeah.
So out of which, what I can say is, if this scar is very low down, and if it is in the area of cervix, so that affect the healing.
Yeah,
If it
because
is
of the cervical mucus coming in the stitch.
there are many hypotheses they have given, and continuous suturing versus interlocking suturing, double layer. We really do not have a single pathophysiological, evidence by which on we can say that this is the causative factor because of which the patients are developing isthmocele. One surgeon is doing surgeries in the same way to many patients, but not everyone is developing isthmocele. So we cannot say that Yes, double layer suturing or single layer suturing is responsible for development of isthmocele. Low level incision, yes, of course. Especially you should be very careful when you are doing a cesarean of a previous LACS. You find that the lower segment is very thin, the upper segment is very thick. Do a suturing in a proper way, because these are the patients which, probably may develop defect in that area. Otherwise, if both the layers are in the same position, suturing technique, of course, everybody has shifted to single layer sutures. Nobody's or continuous suture. Nowadays, nobody is using, sorry, it's not single layer, double layer suture and continuous sutures. Other risk factor, healing, risk of infection, etc., etc. No single cause, madam.
Yeah, especially patient coming in the second stage after 6 centimeter. So their chances of going down is more there. And if you are doing interlock suture, tight necrosis,
Then,
that also
yes.
inhibit the healing process.
Yeah.
So next question by Dr. Manishi Mittal, by Dr. Farinder. Is there any criteria for hysteroscopic versus laparoscopic repair?
Way back, we used to see that whenever the future fertility is desired, better to go for a laparoscopic repair, and hysteroscopic repair is reserved for those having a dysfunction uterine bleeding or recurrent PIDs, etc. I still use this criteria, madam. I'm not a person in infertility patient who go for a hysteroscopic repair of isthmocele. There are many articles I've searched way back and had a big arguments whether you can do it hysteroscopically where the future fertility is desired. So the conclusion is, of course, when the residual myometrial thickness is less than 3 millimeter, better to consider laparoscopic repair. And if it is more than 3 residual myometrium, then you can do certain hysteroscopic procedure or widen the area so that fluid collection will not be there, and probably that can reduce the intracavitary fluid, chances of recurrent infection, or when you're transmitting your embryos or IUI cannulas, it should not come into the way. It should not affect them. So I'm a person who will prefer, if the future fertility is desired, I will do a laparoscopy.
Yeah, rightly told by Dr. Farinder. If patient is asymptomatic, we don't have to treat. We have to treat if patient is either having DOB problem, post-menstrual spotting, abnormal uterine bleeding, or patient is infertility. Then only we treat. For DOB, we can just give hormones, only progesterone, OC pill, everything. But yes, for infertility, we have to treat, and rightly tell that laparoscopy is the best method, especially if the thickness is less than 3 mm, because we can do very nicely repair with the laparoscopic repair. So how do you repair? Can you give few tips by the transillumination, or which method, which suture? All this you can tell us?
Yes, ma'am. So the most critical part in this, first you start with hysteroscopy, you see the defect. Now, when you're seeing the defect, that time you should map the defect in your mind, that my defect is lying and extending in such a way. Then again, you proceed laparoscopically and do the bladder dissection. Now, after that, it is very difficult to identify the lateral extent. So some of us, what we use, we put a scope or there and do a transillumination or do some marking and then excise that area. There are reports also available regarding the peritoneal bends which are extended from one end laparoscopically, from one end of the isthmocele defect to the other end. So if you can identify such peritoneal bands also laparoscopically, they can also take you to the site of the defect. Otherwise, intraoperatively, identifying the defect is slightly tricky. So transillumination and with a bend, we proceed. And then you do it a complete excision laterally. You should be, you should have some visual haptics as well, which can tell you that, yes, laterally you have completely removed this defect. And then you will have to remove the fibrous component as well. So when the fibrous component is out, that time you can do the suturing. Barb sutures are preferred one because it can maintain the good tensile strength. Otherwise, way back we used to use Vicryl. Number 10, it's sufficient. You can do a suturing in 2 layers, interrupted or continuous, anything can do. Results are same, madam.
And some people use Foley's catheter also to
Police to identify the defect.
to identify, yeah, to localize or identify the defect.
If it is really big one, then it can help you out. It depends. See, I have not used Foley's in that particular area. So I do a hysteroscopically assisted one or a bend technique. You create a marking. You do a complete good bladder dissection, and then you can easily identify this thing. Trick is to do a good bladder dissection to push the bladder completely down, identify the defect, and then suture it.
Yeah. So one question by Dr. Ashim Garg for Dr. Chaitanya Chetra. After isthmocele repair, when can we go for embryo transfer?
So at least 6 months would be a good time to heal. Post 6 months, we can go for embryo transfer.
Yep.
Okay. And, yes. And Dr. Farender, what is your?
Yes, ma'am. Exactly, ma'am. It's 6 months is more than sufficient. 6 cycles she should be given. And
What
then
happens if you have patient conceived before that? Healing is not proper.
the chances of repeat cesarean is high. I cannot say because another 6 months are still there. Lower segment is not going to form. So you'll have to keep a watch in such patient by ultrasound and clinically. That's it. Because as far as even first cesarean we do, we say you become pregnant after 3 years or minimum 1.5 years. Because allow the scar to heal. So that's very important, madam. And we are happy if the patient is becoming pregnant spontaneously.
But then chances of abortions are also high. So better to
Correct,
wait
ma'am.
for
Correct.
6 months.
Better to wait. It's always better to wait.
So
Better.
one question, Dr. Chetra, to everyone.
Yeah,
So
I only have placed it, ma'am. So
okay,
post-surgery, many people endorse this placement of silicone catheter so that there is no stenosis. Is it advisable?
So when do you put it? Now?
Post repair, they place the silicone catheter through the internal os and place it there for a week's time.
For a week time after laparoscopic repair or madam or
After laparoscopic repair.
Ma'am,
Like
it
here
must...
in Bangalore, I have seen this practice, sir, where they place the silicone catheter. So if you are very sure of taking only the anterior wall and suturing it, is it actually required? Because some say that there could be a chance of stenosis there. And again, embryo transfers might get difficult or dilatations might get difficult. So better to place a silicone catheter number 14 for a week's time.
Madam, anyhow, the fibrosis is going to take place after 6 weeks. See, keeping a catheter for 4 days doesn't sound clinically good to me. What you can do if you have done the suturing, you can just put a stethoscope, see the canal, you can come out. Even if you are not distending the cervical area or the isthmic area with the stethoscope. You are just irrigating the areas, you can go and see and come out. If you're not that comfortable, put a dilator, plastic dilator easily. Anyhow, you're doing the suturing by putting something in the canal so that
generally a
it can,
dilator, yes.
yeah. So that you want your uterus to be stented and you can take a good suture. You can in between remove the dilator, see the wall, take a good bite through and through full thickness bite and suture it. I don't feel that putting a Foley sounds sensible for me to prevent the stenosis.
And there's no need of HRT also, sir?
HRT?
One question
Madam,
by
HRT is...
No,
not for isthmocele.
Is there any need to get contraception?
Yes.
One question by Ashim Garg. Post repair, is there any need to give contraception?
You don't want the patient to become pregnant for the next 6 months.
That's the only thing. Yeah. Even one of my patient, even if I told not to conceive, but she conceived in 3 months. So every time my finger were crossed till the time. So it's better if you give some ossicle.
The question comes that once they become pregnant, they should go for a trial of labor or a elective cesarean section.
Cesarean. Cesarean.
Good.
Yeah, we cannot go for that.
Yeah, that's a very precious.
Yeah, post-operative care, Dr. Farender. Any care?
Madam, per se, just 5 days of antibiotic post-operatively. Nothing else, no special care.
Yeah.
It's just a simple, usual minimal excess surgery, madam. Nothing else. Contraception is the most important thing which they need to understand.
Yeah. So Dr. Yukti have asked, where can we go for recording? Recording, you can go for IFS website, you can go for IFS YouTube channel. All our young programs, all our journal club, they are recorded. And if you want, we will send also. Farah will post tomorrow in the group only. So all those still not member become the member of this group. You can join by the link. Dr. Farinder, you can also
Yes,
post
ma'am.
your Jaipur. Everyone
Yes,
less
ma'am.
than 45 years can become member of this group, and any age can join this journal club. We are having twice in a month.
Sure, ma'am.
Gitika Garg, incidence of scar pregnancy? One question by Gitika. Dr. Chetra?
I'm not very sure what is the exact instance of scar pregnancy in these patients.
You can say increasing nowadays.
But
Or we are
yes,
finding it a lot.
yeah, a lot. Any size cutoff for isthmocele repair in the infertile patient? Cutoff, Dr. Farinder, for repair.
Symptomatic patient, a residual myometrium of 3 millimeter.
3 mm. It should be
3
3 mm.
mm. Yeah.
Yeah, if very small, it can, no need to operate.
It should be symptomatic one or leading some problem, and then 3 millimeter.
Have you, are you doing histoscopically? Have you done any cases histoscopy also, Dr. Farinder?
For madam, for DUB I have done many. For
Yeah.
infertility, I have not done a single one.
Yeah, because repair will also not be proper if we do
I
histoscopy.
mean, that's my personal individual choice.
Yeah.
There are many very close friend of mine who's doing a lot of hysteroscopic repair, infertility patient hysteroscopy. I'm yet to see the long-term outcome, but I'm still not convinced. I prefer to do it
Atul, make
laparoscopically.
Dr. Nisha co-host. Atul? Yes, for the infertile patient, we would like to do laparoscopy also. Number layer of Crozer for repair, 2 layer.
Yes, ma'am. 2 layer is sufficient. Or with barb, if you're comfortable, one layer is also manageable. But 2 layer is preferred.
Any role of leuprolite where patient doesn't agree for surgery?
For isthmocele, no,
No.
ma'am. It's a surgical disease.
Yeah, it's a defect. How can we close by the leuprolite? Yes, if patient is very small, no symptoms, only coming with DUB, there we can give ocipil, progesterone. But if the defect is around 3 mm, infertile patient, symptomatic, we have to do surgery. And it's a really rewarding surgery. We get result after that
Yes,
if it transfer. Atul, you can unmute Dr. Nisha. So any other message, Dr. Farinder, you want to give here? Any other tips, any other message?
I mean, all nowadays, madam, everybody is looking in the lower uterine segment. So whenever a patient with previous cesarean section comes to you for DUP, for infertility, please see the lower uterine segment with partially filled bladder. It will help you out in diagnosing this small entity, which you can take care later on. I see lot many reports, lot many photographs showing isthmocele, but they're not mentioning the defect or the isthmocele in their ultrasound report. So that's the only thing, ma'am.
Yeah. So, Dr. Chetra, you also want to say any message for everyone?
Ma'am, any isthmocele, especially in patients who are infertile, particularly those presenting with intracavitary fluid. So I would say even if the defect is small, and if there is an intracavitary fluid collection, definitely she is a candidate for repair.
Correct.
Correct.
That's a symptomatic isthmocele. Symptomatic one needs treatment.
So thank you very much, everyone, for the joining. So Chitarya has given good job.
Yes.
So all of you are welcome to present. You give us your topic. You can present from the infertility, IVF, embryology, reproductive surgery, any topic you can take. We can have a good discussion, and we'll do mentoring section also in between. So anybody who want to present, tell us, give us your good journal topics. We'll do the selection accordingly. And we'll give certificate also next day. And you all who have participated till now will make you faculty in the fertilization also. So with this, I think we can wind up.
Ma'am, just wanted to say thank you. Thanks to you. Thank you so much for always being there. And you have taken care of the whole thing in a very good manner. Like the whole Young Turks group look forward to ma'am's guidance and all. Thank you, sir. Thank you for giving us with beautiful insights into Isthmocele. It is a very difficult topic and I think more difficult to heal also. But thank you so much for providing us this. Ma'am, thank you so much.
Yeah,
Thank you, madam. Thank you
Thank
so
you,
much. Thank
everyone.
you. And thank you,
Yeah, so
Dr.
with this,
Chitra.
Thank
and
you.
we meet then a fourth Friday.
Thank you, Dr. Chetra, for giving
Thank you,
us
ma'am.
this beautiful this thing. And I just want to say one more thing. Chetra, we had another person who was doing this, but unfortunately the person felt ill and could not present. So Chetra took this opportunity, like within 24 hours, she prepared the whole thing and did this presentation.
I should thank
Very
Aisha
commendable,
for
very
this.
commendable,
Thank
very
you so
commendable.
much.
Round of applause for Chetra, and
Yeah.
we such enthusiastic young Turk.
Yeah, and she's
Thank
a
you
very
so much.
intelligent.
Yeah,
Thank you.
definitely.
Thank you so much.
Thank you, ma'am. Thank you, sir. Good night.
Thank you, madam. Good night. Thank you
Bye.
so much.
Thank you, Dr. Farinder.